Assalamu alaikum. My name is Dr. Shafiq Cheema. I'm professor of nephrology at Allama Iqbal Medical College, and I'm diploma at American Board of Nephrology as well as internal medicine. I'm also fellow of American Society of Nephrology. Today we will be talking about hematuria or nephritic syndrome. So specifically, we will be talking about glomerular hematuria because this is different from any other hematuria, and we will get to that. Um, the we have discussed in one of our previous presentation and lectures about proteinuria, albuminuria, and nephrotic syndrome, and we went over the causes of it, including minimal change disease, membranous nephropathy, FSGS, and systemic causes like amyloidosis, diabetes, and HIV. Today we will be talking about hematuria, which could be asymptomatic, non-glomerular hematuria, red blood cell coming, say, from the bladder, that's not coming from the glomeruli, or glomerular hematuria. And then the terminology you might have heard about glomerulonephritis. Glomerulonephritis is when you have some proteinuria or albuminuria with some red blood cell in the urine that indicates inflammation. So that would be glomerulonephritis. In all other causes of nephrotic syndrome, you would not see itis at the end. It's minimal change disease, it's membranous nephropathy, FSGS, but all the other causes of glomerular disease have itis at the end. So that is glomerulonephritis. The main difference is you have to have red blood cell in the urine, and they have to be of glomerular origin. Like you could have proteinuria because of diabetes, and some red blood cell because of UTI, but those red blood cell would not be of glomerular region. And how do we know if they're coming from glomeruli or not? We will discuss in the next few slides. Then there is nephritic syndrome, when nephritis is also associated with azotemia, hypertension, oliguria, that is nephritic syndrome. And sometimes your creatinine is increasing very fast. Usually in nephritis and nephritic syndrome, creatinine is stable and it gradually increases. But in rapidly progressive glomerulonephritis, creatinine is increasing over a period of hours to days and weeks, not over months to years. So creatinine could be 2 today, 1 week later 2.5, and then 3, and then 4. We won't have time to discuss in detail RPGN, but it could be caused by immune complex diseases. Like all the causes of nephritis could also cause RPGN. And then there could be antibody against the antigen, basement membrane, that could be anti-GBM disease or Goodpasture syndrome if there is a respiratory involvement. And then if there is no immune complex, no antibody against the basement membrane, it's without any immune deposit, that's post-immune or ANCA-associated vasculitis like vaginous granulomatosis or GPA or MPA or Church-Strauss. So we will talk about etiology and management and so forth. So this this particular presentation and lecture is basically focusing the medical officer, the house officers, the GP, and more precisely for the final year medical students, MBBS students. So just to recap, what's the difference between nephrotic and nephritic pattern? In nephrotic pattern, you have more proteinuria, so hence you have more edema, and you have more decreased albumin because of the same reason. In nephritic, you have less proteinuria, so you have less edema, and albumin might be normal. But the difference is basically the red blood cell. So you would have a lot of red blood cell or red blood cell cast in the urine. Nephrotic syndrome usually should have a bland urinary segment, no red blood cell. But finding 2, 3, or 4 red blood cell usually does not specify nephritic. It could be a possibility in nephrotic syndrome, like some cases of FSGS could have few red blood cell, or minimal change disease in adult could have some hematuria. Macroscopic hematuria, when you have visible blood in the urine. Microscopic, if you have more than 3 red blood cells, at least on 2 to 3 different urinary sediments, not in the setting of infection. or after exertion or something. That's microscopic hematuria. So there are so many causes of hematuria like kidney cysts, kidney tumors, blood vessel disorders, stones, cancers, tumors in the ureter, stone in the ureter, cystitis, prostatitis, urethritis. But we are going to be focusing on the glomerular causes, secondary to glomerular nephritis, the causes of hematuria and nephritic syndrome and nephritic pattern of injury. So whenever you have a patient with hematuria on the complete urine, in addition to history and physical, urine complete, you could have either no hemoglobin and no RBCs, then you look for some other causes of red urine. There are certain foods which could give you red color in the urine. But if you have RBCs and no hemoglobin, then you check RBC morphology and then you differentiate glomerular, non-glomerular based on if there are any distorted RBCs or any casts. Similarly, sometimes you could have hemoglobin only. That could be because of hemoglobinuria or myoglobinuria, but no red blood cells. So if you see no RBCs but large blood, that could be a manifestation of rhabdomyolysis or hemoglobinuria. Then how do you know it's glomerular versus non-glomerular hematuria? So when it's coming from the top, it changes color to brown or tea color, just like a GI bleeding. You could have a coffee ground emesis. You could have RBC casts in the cases of glomerular hematuria or distorted RBCs. You would have some proteinuria, some dysmorphic RBCs. In non-glomerular, it would be fresh blood with clots without any proteinuria, and there would be no casts or distorted dysmorphic red blood cells. This is the cast, different red blood cell make a cast. So nephritic syndrome, as I said, you could have nephritis without nephritic syndrome, but all the cases of nephritic syndrome have to have nephritis. When nephritis manifests, it's severe and it manifests in the form of oliguria, hematuria, azotemia, hypertension, edema. That is nephritic syndrome. There are different causes of nephritic syndrome or nephritis or hematuria. Local causes could be mesengeoproliferative GN or IgA nephropathy, Alport syndrome, thin basement membrane disease. In fact, these are the three causes which could give you isolated hematuria sometime. No protein, just blood. Post-infectious or post-streptococcal glomerulonephritis, membranoproliferative glomerulonephritis, mesengeoproliferative glomerulonephritis. So there would be itis at the end. And then systemic disorders like SLE causing lupus nephritis, Hanoch-Schönlein purpura, vaginous granulomatosis, Goodpasture syndrome, HUS, hemolytic uremic, sickle cell disease could also cause it. So why do we do all these different tests? And I'll explain it. CBC you would like to do to see if there is any anemia or any hemolysis or anything like that. Then serum electrolyte to see if there is any azotemia. Serum albumin to see the degree of proteinuria. C3, C4, many disorders causes hypocomplementemia like lupus nephritis, RPGN, cryoglobulinemic. ASO titer for post-streptococcal GN, ANA for connective tissue disorder, DSDNA for lupus nephritis, ANCA for ANCA-associated vasculitis, C and P ANCA, protein and albumin in the serum, that is important also, cholesterol to see what is the degree of hyperlipidemia, a 24-hour urine creatinine clearance as well as protein, and ultrasound to see the kidney size, echogenicity, and eventually the final diagnosis is made on biopsy. So this is the initial workup for any patient with hematuria. Then history is very important. If someone has a family history of hematuria or abnormal urine, there are cases of familial nephritis like Alport syndrome. They could also have deafness. Rash arthritis could signify SLE and lupus nephritis. There would be low C3, C4 and increased ANA. If someone has hemoptysis and bleeding tendency with some microcytic anemia, so you will think of some pulmonary renal syndrome like Goodpasture syndrome. A recent upper respiratory tract infection, skin infection could lead to post-streptococcal. Synpharyngitic GN signify IgA nephropathy. There would be normal C3, C4, AS. So the difference between IgA and post-streptococcal. This would happen after a few weeks, 1 to 2 weeks. Synpharyngitic IgA nephropathy would happen the next day, hematuria and proteinuria. Similarly, if you don't find any sign and symptom, but urine shows proteinuria, hematuria, biopsy might show membranous nephropathy or membranoproliferative GN. These are the causes of persistent hematuria without any proteinuria, like IgA nephropathy, Alport syndrome, and thin basement membrane disease. If someone has persistent microscopic or macroscopic hematuria without proteinuria, and that is of glomerular region, that could be one of these three, because people could have cystitis and that could give you red blood cell, but that's not of glomerular region. Thin basement membrane disease is a familial disease, mutation in type 4 collagen leading to thinning of the basement membrane. It could present with usually just with hematuria. It could be microscopic or gross, minimal proteinuria, no proteinuria, some hypertension. The long-term prognosis is very good, and the diagnosis is made on the electron microscopy. Alport syndrome, X-linked, autosomal recessive. Presentation is same, hematuria, some proteinuria. They could have corneal erosions, deafness. It's an inherited disorder. Mutation same, type 4 collagen, like thin basement membrane disease. And it could lead to ESRD as opposed to thin basement membrane disease. Acute post-streptococcal glomerulonephritis, the infection basically causes antigen-antibody complex to be deposited in the subepithelial region. These are subepithelial humps. Patient present with brown, tea or cola-colored urine. They could have some proteinuria, as happened in nephritic syndrome, some edema, some mesothemia, some hypertension. It usually does recover, but sometimes you do need some medical therapy. These are the subepithelial humps of post-streptococcal GN, and there is a diffuse proliferative GN, and this is the immunofluorescence. So you treat with ACE, ARB, calcium channel blocker. Sometimes a short course of steroids is needed. You manage them on the lines of nephrotic, nephritic, volume. For the volume reduction, you will restrict their sodium. You could give them diuretics. You could treat hyperlipidemia. Usually hyperlipidemia is not a feature of nephritic syndrome, but if someone has nephrotic range proteinuria, they could have it. IgA nephropathy, Berger disease, also called mesenchioproliferative GN, could present with microscopic hematuria, gross hematuria, usually immediately after respiratory tract infection. It could have mild proteinuria. It could even have nephrotic range proteinuria. It could present with nephritic syndrome or RPGN. So all kind of manifestations are possible. And this is the mechanism of deposition of IgA. It leads to mesangial deposits like this and proliferation. So it's a mesenchioproliferative GN. You treat all of them with ACE, ARB, and sometimes we need glucocorticoids for this. Systemic manifestation of IgA, which could present with the vasculitis, immune complex deposition, rash, arthritis, abdominal pain, hematuria. This is usually the case in young children sometime, and that's sometime a USMLE question. Abdominal pain, rash, and hematuria with some arthritis could indicate Hanoch. So we got briefly disconnected. I think we did cover Hanoch-Schönlein purpura. So now we will be talking about good pasture syndrome. Good pasture syndrome is when you have pulmonary and renal involvement. Anti-GBM disease is when you just have the kidney involvement. And it could manifest in the form of hematuria, proteinuria, hypertension, renal failure, and there would be anti-GBM present in the blood. You would have hemoptysis in the good pasture syndrome. Anti-GBM disease would just have renal manifestation. You diagnose them based on the glomerulonephritis, pulmonary hemorrhage, anti-GBM antibodies in the blood. You confirm the diagnosis with renal biopsy, and you treat them with the plasmapheresis as well as high dose of cyclophosphamide and solomedrol or methylprednisolone. Lupus nephritis is very common. You need to know the diagnostic criteria of SLE. You need to be able to come up with 4 out of 11 of those things to diagnose SLE. Then it could present in the form of nephritis, nephritic syndrome, or RPGN. Commonly seen in female in second and third decade. Patient could present with hematuria or proteinuria, nephritis, nephritic syndrome, RPGN, and even nephrotic syndrome. It could lead to renal failure and they could go on dialysis. They could also get a transplant. Hypertension is a manifestation, like in all cases of nephritic syndrome. It is further classified based on the histopathology into 5 classes. No changes in the class 1 of lupus nephritis, mesangial-proliferative GN, focal glomerulonephritis, diffuse proliferative glomerulonephritis, and membranous. And there is also class 6 in which you have sclerosing glomerulonephritis. The treatment is with hydroxychloroquine, steroids, and MMF or Cellcept has a role for the induction as well as for the maintenance. Steroid and cyclophosphamide can be used for the induction and maintenance, as a thioprine or immuran has a role, and rituximab, especially in the resistant cases. So this was all about nephritis, hematuria, RPGN. I did not go into the details of RPGN, and we have just basically touched these topics a little bit. Each one of them, like even one class of lupus, say diffuse proliferative, you could have 2 hours lecture on it. But since this was designed not for the renal fellows, this was basically designed for the medical students as well as for the GPs. So I just kept it very simple. With that, I would say thank you, and I would recommend you to subscribe the channel Good Doctors by Dr. Shafiq Cheema. Currently, we are putting lectures for GI and nephrology, and we will be adding more topics. In the comments, do mention what kind of topics and subjects and the speakers you would like to have on board. Thank you very much. With that, I would stop the recording.